The Self-Care Learning and Discovery series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Hello, everyone, and welcome to today's session, Scaling Up Self-Injectable Contraception, Promising Strategies, Practical Questions. I'm Ebony Fontenot, a Senior Technical Advisor at JSI, and I'm thrilled to be your moderator for today's session. Before we dive in, I want to just provide a few housekeeping notes. First, if you haven't already, please introduce yourself in the chat. Write your name, your organization, and where you're joining from. Second, as mentioned in the video, this session has live simultaneous interpretation in English, French, and Spanish. At the bottom of your screen in the toolbar, click on the button labeled Interpretations. Choose which language you would like to hear the session delivered in, English, French, or Spanish, and then you'll be added into the audio channel of your choice. Finally, we ask that you remain muted throughout the event, unless invited to come off of mute. Thank you so much. Next slide. During today's session, you'll hear from about 5 different speakers, and they'll share their experiences, their organization's research, and impact on self-injectable contraception. Because we have so many speakers, we'll ask that you please do share your questions in the chat. We'll be keeping track of them, and we will do some Q&A at the end and through the chat as time permits. So I'm going to kick us off first with a quick icebreaker and a little quiz. Next slide. Is self-injection of DMPA-SC endorsed by the World Health Organization? Your answer choices are yes, no, or unsure. So far, I'm seeing most people say yes. We have a few, 1 or 2 unsures. Okay, so yes, the World Health Organization's evidence-based family planning global handbook for health providers endorses self-injection of DMPASC as an option where appropriate information and training are made available. Referral links to a healthcare provider are strong, and women who self-inject are monitored. Since 2019, the WHO has maintained a strong recommendation for self-injection as a self-care approach. So if you've been joining the sessions, I'm sure this is not your first time hearing about self-injection, but we look forward to providing some more context and sharing lessons from the field throughout today's session. And throughout the session today, we'll likely have one or two more poll questions. So do stay ready to answer those questions. Next slide. I'll start us off by introducing our first speaker, Alan Namagembe. Alan is the Deputy Project Director and Monitoring and Evaluation Lead on the Uganda Private Sector Family Planning Facilitation Project at PATH. She is a global and regional expert on contraceptive self-injection and self-care approaches. Alan, over to you.
Thank you, Ebony, and hello, everyone. Thank you for joining. Next slide, please. Yes, I'm going to present results from a rapid assessment of progress and evaluation of DMPASC self-injection public sector service delivery in Uganda. Next slide. Why did we conduct these rapid assessments for progress? There is substantial facility and district level variation in self-injection, which I'll call SI, service provision and uptake. System level barriers such as high rates of DMPASC stockouts, individual level barriers such as client perceptions of SI may be impeding scale up of self-injection. So we wanted to understand factors which are underlying the variations in the uptake of SI across public sector service delivery points, including identifying facilitators and barriers to uptake. Specifically, we wanted to determine emerging health system barriers and facilitators that influence SI uptake, assess whether attitudes and behavior of providers and stakeholders impede or accelerate SI uptake, to identify the nature of the challenges to SI uptake from the perspective of clients, and to establish clients' perceived quality and overall satisfaction with FP services, specifically SI services. Next slide. We collected this data between September and November 2022. We sampled 43 facilities in 8 districts. 3 of these facilities were selected because just to capture data from community-based providers, because we encountered some inactive community programs in some facilities. Facilities were purposely sampled based on district facility level, whether they were hospital, health center 4, 3, 2, and of course the community health workers, and SI activity level, whereby SI activity level represents the percent of DMPASC clients that self-inject, and was divided into 4 categories based on the median and interquartile ranges, whereby very low were facilities who had less than 4% of their DMPASC visits for self-injection. Low, 4 to 20%, median, 21 to 40%, and high, having over 40% of their DMPASC visits being SI. At each facility, we sampled 6 clients. 3 were facility-based clients, and then 3 community-based clients via exit interviews. 2 providers were also sampled, 1 facility-based and 1 community-based, plus their facility in charge. The inclusion criteria, the clients had to be FP clients at the study facility and should have received either DMPSC or DMPIM during the visit. And then providers had to be FP providers. We used both structured surveys and in-depth interviews. Next slide. Some of the questions are: stockouts a bigger issue at low SI activity sites? This slide shows stockouts of DMPSC and IM. Both stockouts at the time of data collection, the dark purple, and stockouts in the past 3 months, light purple. We see that high SI activity sites were substantially less likely than very low SI activity sites to have a stockout of DMPSC, 10% versus 40%, and were more likely to have a stockout of DMPIM. These stock challenges may be impacting SI uptake, whereby we know IM cannot be used for self-injection. So sites with IM but not SC stock will show lower SI uptake. Additionally, providers may prioritize provider-administered when SC stock is low, using 1 unit per client for provider administration rather than multiple units for the self-injecting clients. In our studies, providers at low SI sites reported not sending units home with SI clients due to stock shortages. Next slide. At low SI activity sites, is training offered less frequently or is training less successful, or both? And these are reports from clients. We wanted to understand the SI cascade. If clients were told about SI in the first place, if they received SI training, and if they actually self-injected after the training. Each of these questions were filtered based on the prior one. So, of clients who were told about SI, how many received SI training? Of those who received training, how many self-injected? Please note that this slide was restricted to data from facilities that did not report a current stockout of DMPSC, as we wanted to understand the SI cascade in facilities where SI was actually a potential option that day of the client. Clients at high and median SI sites were significantly more likely to be told about SI and to self-inject at the end of their SI training compared to clients at low and very low SI sites. There was no significant difference in likelihood of receiving SI training of those told about SI across SI activity levels. Next slide. The next question is, to what extent are providers at low SI activity sites less receptive to self-injection? Providers at both high and very low SI activity sites felt that SI training was a worthwhile time investment. However, providers from very low SI sites reported being less receptive to SI across a number of dimensions. They perceived their colleagues and in-charges to be less supportive of SI. They were more likely to agree that there was no time to train women on SI, and they were more likely to believe that their clients would be too scared to self-inject, and their community had negative views on SI. Next slide. Another question we explored: do providers at low SI activity sites have more workload constraints that make it challenging to offer SI training? Although providers at the low SI sites felt that SI training was a worthwhile time investment, as we've seen in the previous slide, they didn't think that time to train was feasible to incorporate into their workload. This may be related to the lower success rates of clients self-injecting at the end of SI training at the low SI activity sites, where the time investment may be seen as wasted if the client decides on provider administered after the training session. Interestingly, the number of FP providers and the reported workload were comparable across SI activity levels. Next slide. The other question explored, are there differences in the quality of SI training provided to clients? And these are still client perspectives. The figure on this slide shows the percent of respondents who agreed or strongly agreed with each statement, with clients from high SI activity sites in dark red and clients from very low SI activity sites in light red. Overall, clients at high SI sites were more likely to have a positive view of their SI training compared to clients at very low sites, although not across all dimensions. Agreement was similar between high and low SI sites for dimensions like understanding the steps, having enough time for a thorough training, and having a competent and informed trainer. However, clients at very low SI sites were much less likely to report feeling confident to self-inject at the end of the training, 47 versus 81, that their trainer was encouraging and patient, 84 versus 100, and that all of their questions and concerns were addressed, 74 versus 88%. Next slide. The other question we explored, are there differences in characteristics of clients trained in SI that might underlie differential uptake of SI across sites? Across board, clients at very low SI sites reported less confidence in the self-injection process, including across all critical steps and in self-efficacy to overcome challenges like initial failure, lack of outside support, or fear. Next slide. We also explored what extent are differences in SI activity due to low receptivity to self-injection among clients. There was a high level of interest in self-injection overall among the study participants, with over 3/4 of the client respondents already self-injecting or having interest in self-injection. This interest was lower among clients at low SI activity sites, with an over 10% point difference between high and low sites. Next slide. As I conclude, what are our key findings and next steps? There are a multitude of factors that, rather than a single challenge, that underlying the differences in SI activity levels across sites, including both system-level constraints as well as barriers at the level of individuals, both clients and providers. We've highlighted that a greater share of very low SI activity sites face chronic DMPS supply challenges, and providers at these facilities report not giving out units to SI clients due to stockout issues. Providers at low SI sites were also less likely to bring up SI during the visit, and clients at these facilities were less likely to self-inject at the end of the SI training. Providers from very low sites were less receptive of SI across a number of dimensions. They perceive their colleagues and in-charges to be less supportive, and they felt that their communities had negative views on SI. Clients at very low SI sites were also less likely to have a positive view of their SI training and were less confident to self-inject compared to clients at high activity sites. What are our next steps? We want to continue sharing these findings with our Ministry of Health, district health teams, and implementing partners so that we develop action plans to address most of the prominent barriers. We want to explore cost-effective approaches to improve quality of FP counseling, particularly among facility-based providers. That's where the biggest challenge was. We also want to explore approaches to improve provider receptivity to self-injection and conduct additional rapid assessment for progress studies to understand cross-country barriers and facilitators to SI scale-up. Thank you. And back to you, Ebony.
Alan, thank you so much for providing that overview of your rapid assessment. We were able to get information on client perspectives, provider perspectives, and the ever important supply chain So thank you for sharing those perspectives. If you have any questions for Alan and her team, please do share them in the chat. We're going to continue on, but when we circle back in a little bit, we'll have time for question and answer. So please do write down your questions so that we can come back to them. Up next, we'll hear from Lusungu Makandwere, who is a registered nurse midwife who is working with Family Health Services as a DISC project coordinator. She joined FHS in 2021 as a service provider and has since then risen to 2 midline managerial roles. Through the Discovering Innovation in Self-Care project, DISC, Lusungu, together with the FHS managing team, is committed to supporting the Malawi government in expanding access to self-care services in response to the needs of adolescents and youth. Lusungu, over to you.
Thank you so much, Ebony. Or like she rightly said, my name is Lusungu Kandawile from Malawi, and I work with family as a DISC project coordinator. So welcome everyone. Can go to the next slide. Next one as well. Ebony, can you do the next slide? Thank you. So that's my, hello? All right, so that's my project outline. That's what I'll be taking you through, the project overview, the rollout of Moment of Truth, the reach trends that we have had so far, and then the demand creation activities that we have as FHS, as well as the challenges and efforts that we have made. All right, so Malawi as a country do fall into one of the countries that has a high unmet need for family planning services for adolescents. And currently ours is at 1.5%, and that is in accordance to our multiple indicator cluster survey. The current one that we have is the one that was done in 2019 to 2020. We are yet to finalize with the recent cluster survey. So data that we're using, and that has been much attributed to the poor access to family planning, including self-care products among our youth, such as the DMPCSI. So as FHS, we rolled out the DISC project in January, and our main, we wanted to support the Ministry of Health, the Malawi Ministry of Health, to ensure that they scale up the contraceptive self-care interventions among the youths, while focusing mostly on the DMPAS as self-injections. So specifically, we want to build capacity of family FHS outreach providers and TUMSA. So when I'm talking about TUMSA, basically it's just a social franchise name for clinics that are registered under our social franchise, which is TUMSA, and it simply means care. It's a Swahili word which means care. So we had Moment of Truth in those private clinics as well. And then we also wanted the awareness and demand for DMPASC, because we thought maybe Malawian youth are having hiccups because they don't know to what extent they can acquire the self-care. So we thought, let us make noise to ensure that the youth are aware of what we are and see the results. So currently we are in 14 districts out of 28 districts in Malawi, where we are. The district is a catalytical project, and it's working with the other two programs, that is Sogolanga, which simply means my future, and Nzatonse, which is inclusiveness. Yeah. Next slide. All right, thank you. So we rolled out the truth approach in January, and it should be noted that for the rolling out of the Moment of Truth in 2022, our uptake of DMPA was as below as 2%. And following the training conducted, we have seen great gains, whereby there's been an increase from 2.2% from January this year up to 9%. That was by June this year. So for us, that is a major indicator that we are doing something on the ground, and we are reaching out to people, and people are aware of the method that is ASI. Next slide. All right, so the graph that you're looking at simply shows the progress that we have made so far. As a country, we have been met with high levels of stockouts throughout the project, but we were mostly hit in the month of July, in the ended quarter, that is July to September. But despite that, we have seen a lot of gains, whereby we have managed to see about 40,000 visits by September so far. So it should be noted that out of the 40,107 SI visits that we have had, that we have registered with, 64% of those are adolescents, starting from the age of 15, as you can see, to 24. So adults are only contributing about 36% of the reach that we have had. So as FHS, we believe that maybe some of the reasons that method is more appealing to the youth is that because it ensures privacy, where they are able to process and ensure provision at their own allocated time in their home, rather than coming every now and then to our highly populated health cities every now and then to acquire other self-care products as well as other family planning methods. And then we also believe that the gain we have seen so far will assist the Malawi government to achieve the vision that we have for the health sector strategic plan 3, and then as well as the 2023 vision, which will ensuring youths to lead healthier lives and to contribute to the country at large. Next slide. So it should be noted that FHS is not only out there providing information on DMPA. We do provide all the family planning methods, and our messaging also carries messaging for all the family planning methods. That is to say, we are still our clients to make an informed choice when it comes to family planning services. That is why we are showing the where it shows the method mix that we have registered with so far, starting from January. So it can also be noted from there that the DMPA itself is not actually family planning service, but rather it's the previous month, starting from April to July, it was the second leading injectable that was being by our clients. Yeah. Next slide. Yes. So I'm also showing gloveware just for interest sake to see that our clients, we are still encouraging our clients to make an informed choice when it comes to family planning methods. Still that most of those that are accessing, for example, long-term methods, a few of them have been able to be switched to self-injections, and mostly the ones that are switching are those that are switching from the IM injectables, and then the second is switching from provider injection DMPA SC. Next slide. Yeah, so on the demand creation activities, yes, we have managed to we did manage to train our demand creation activities as well in moment of truth, because we believe, because they are the frontliners for the information in our communities, they should be able to have the and ensuring that they do provide the adequate information to our clients right when it comes to moment of truth. So they are also able to tackle fears that clients as individuals might have when it comes to self-injectables. We also went as far as training our community volunteers through our already existing programs. That is, when they are conducting actions, they are able to trickle down to provision of information on injectables. Not only that, we also managed to adapt messaging, the messaging that they use as volunteers, as our providers, and as well as the operation teams, comes from the message adaptation that we did, viewed and adapted messages from Uganda, Nigeria, and the local messagings are from as well. And then from there, we also managed to produce posters. We managed to do boards and animated videos so that we can reach out to many youths as we can. And lastly, we have also been conducting community meetings where local authorities or demand creation teams are able to interact with the youth and share information related DMPA, SC as injectables. We have also been conducting youth office, whereby during weekends, when we know the youth are away from schools, they should be able to come to us and access our outreach teams. And we do focus in areas where we know we find larger groups of the youth. Yeah. And yeah, so it hasn't been a bed of roses. We have had a few challenges that as FHS we feel that have been a bit of a setback, that we've been far off by now. And some of those, the most attributing challenge was the issue of stockouts. So as a country, as I already stipulated in the to say, as a country, we have been hit with high levels of stockouts, especially in the quarter. And because of that, it also affected the way we had rolled moment of truth in the private sector clinics, the TUNZA. We had to, because there wasn't enough stock in the country to be able to distribute to the trained clinics and providers. So we feel had a setback on our implementation, that even the gains that we would have managed to gain more if the stock status was a bit different country. So our efforts from our side, we have been doing the distribution of commodities, those that are done on monthly basis in districts, as well as supporting the Ministry of Health at large to relocate commodities from the north, because from the northern side, up to a bit lower, and as well as the population is a bit lower as compared to the southern and the central. So we have been able to coordinate with the Ministry of Health for the commodities. And then we also have poor reporting rates in private facility sectors, because they are supposed to be reporting to the Ministry of Health as well. We felt like maybe the channel for reporting wasn't that complete or inclusive as we want it to be. So as FHS, we are to conduct targeted supervisions to the TUNZA facilities. And we also see that it might have been a setback that we would have or we would have reported to have reached out to more clients with SI, DMPA, SC, SI as a service as compared to what is reported. And then lastly, we have had low client flow for family planning services, including DMPA in TUNZA clinics. So like I already said, there was delay in rolling, and even after rolling out due to the stock out levels. The client reach in Tunza clinics is not the same as at our health sector facilities, but we would also want to improve. We would want in Tunza clinics. So we feel that that has been a setback, and as an organization, we have arranged that for each and every private sector clinic that trend in a moment of truth, they should be able, we should be able to reach a community mobilizer. We should be able to go through into the communities and increase awareness of the service so that people can be able to access it from the nearby private sector facilities as well. Yeah, so basically that is all that I had from Malawi. And over to you, Ebony.
Lusungu, thank you so much for sharing that. It's great to get information on adolescent girls and young women, and also the method switching is always a very interesting question when it comes to DMPSC. So it's great to see those data. If you have any questions for Lusungu, please do share those in the chat. Again, we'll come back together for a question and answer shortly. So please do share. Next slide. I'll move us along to our next presenter. Veke Donzo is a skilled monitoring and evaluation manager at the Clinton Health Access Initiative, Liberia, who passionately conducts research and evaluation to drive implementation towards success across various programs. Veke, over to you.
Thank you, Ebony. Good morning, good afternoon, and good evening to everyone, respective to wherever you are joining from. So to start, Ebony, if you can go next. So just to give you a background as to how this study we are going to be presenting on came about. In 2018, Ebony, if you go next. In 2018, next please. The DMPA-SC Provider Administration was first introduced in Liberia through the community health system in one of the 15 counties. So based on the lesson learned from that pilot, the Ministry of Health developed DMPA-SC scale-up guideline to guide all activities required to scale up the product, including self-injection. As set up in that guideline, the Ministry of Health, in partnership with the Clinton Health Access Initiative, gathered Liberia-specific evidence on the acceptability and feasibility of DMPA-SC self-injection. Next, Ebony. So some of the key questions that we wanted to answer in this study included, among others, clients' level of acceptance, satisfaction, likelihood to continue, and likelihood to recommend DMPA-SC-SI to others. And we also wanted to know providers' perception of DMPA-SC acceptability, feasibility, and client capacity to self-inject. Next. To do that, next please. So to do that, to answer the questions of interest, what we did was to use a mixed method approach. So we purposely selected clients who chose SI at the study facilities and consented to be part of the study. We also engaged those who refused, as well as providers who were trained on the MOH guidelines. So we use quantitative surveys and focus group discussions to be able to answer the study questions. Next. Please go back later. So the previous slide, Ebony. Okay, the previous one. Is this? No, not next. Previous. Okay, thank you. Okay. Ebony next. So for clients who chose SR, service provider were first required to train them. Ebony, the next slide. Thank you. So for clients who chose SR, service providers were first required to train them on how to self-inject. So the demonstration was done using a model that was made out of condoms filled with curtain. So the study found that 78% of the clients needed just 45 or less on the training and practicing. 71% practice once or twice on the model before being able to successfully self-inject. And after receiving the client training, the study found that 95% of clients could self-inject successfully. And out of the self-inject clients who participated in the follow-up survey, 95% of them also did a re-injection successfully. Next, Ebony. So the top reason reported by clients for selecting a self-injection was to reduce the travel time to health facilities and also to reduce the cost associated with coming to the facilities. And other people also mentioned the fact that they wanted to have privacy and also have autonomy to administering the contraceptive. So self-injection was a better way for them to do that. Next week. So on the question of how easy was it to self-inject, clients overwhelmingly reported that self-injection was easy or somehow easy for them. And 83% reported that their first self-injection was not painful, while 91% of those who re-injected at home reported that it was not painful, so it was easy for them to do. 89% of the clients reported that they were able to self-inject at home on time. So they did that just within the 1 week time period that was prescribed to them to be able to re-inject. Next slide, please. So one of the key questions that was raised to the Ministry of Health when there was a suggestion to have self-injection was the issue of storing the product at home and how the waste to be disposed of. So that was a key question. And from this study, we were able to find that most clients store their products in handbags and suitcases so that they were able to keep it away from their kids. So half of them reported that it was very easy to find a good storage place in their house. And as to how the waste product was disposed of, the most popular method was placing it in a puncture-proof plastic bottle to bring it back to the facility, or dropping it in a pit latrine. Yes.
Becca, before you continue, I'm just going to ask if you could try and speak slower, a little bit slower, and speak up. I think that we're having a little bit of connectivity issues that is challenging the interpretation.
Thank you. Okay. So for clients who refused SR, so those that did not choose self-injection and consented to be part of the study were administered the client's refusal survey. And for that part of the survey, we found out that the top alternative family planning method that were chosen were the DMPA-SC provider administration, where 46% of the clients chose the provider to administer the product, and 29% also chose DMPA-IM. And then this suggested that most of the clients chose injectables as an alternative method for family planning. So if effort is made to address the client perceived challenges, SI could be a better method for most clients. Next. So when asked to think about the challenges associated with SI, clients and providers have similar observation. The challenges included how to insert the needles, knowing where to inject, remembering the sequence of the steps, and etc. Interestingly, clients perceive fewer challenges for themselves compared to provider perception. Next slide. So On the overall client satisfaction, all the clients who chose SR during the study said they would like to continue with it. 91% said they were very likely to continue, while 9% said they were somewhat likely. So, and 89% of the clients said they were likely to recommend SR to others. 69% were reported that they were very confident in doing the next injection on time and correctly. Next. So, on the provider perception of term self-injection, they overwhelmingly agree that DMPA-SC-SI should be available as an option in all facilities. And they also agree that training women in self-injection is an investment that will save time in the long run. The clients, they also said that the clients are capable of self-injection if they wanted to be. And correspondingly, they also disagree to statements such as, if women are comfortable with DMPA-RM, there is no reason to introduce the DMPA-SC. And they also disagree to the statement that contraceptive injections should only be given by healthcare workers. So providers were comfortable that self-injection should be an alternative in the facilities. Next, please. So in conclusion, the overall clients and provider identify SR as an acceptable and feasible family planning method in the Liberian context. And findings suggested that the facility provider in Liberia can effectively counsel and train on DMPA-SC, and clients can effectively self-inject at home. And this presented an opportunity for us to expand the contraceptive method base in Liberia to include DMPA-SC-SI and scale up the SI nationwide. And another conclusion, in addition, was that future analysis could be conducted to understand whether any social demographic characteristics have a bearing on the client's experience. Thank you all for listening. Over, Emily.
Vicky, thank you so much for that overview. It's great to see the potential for DMPA-SC and self-injection in Liberia. At this time, we're going to have a quick break and do a little poll. It should appear on your screen. This is another quiz question, so just give us a second and we'll have it up on your screen. Okay, how many countries have authorized DMPA-SC for self-injection? At least 12 countries? At least 37 countries? At least 56 countries? Okay. We're seeing responses across all of the options. Most people thinking at least 37. We'll give more folks a chance to answer. Okay, it looks like folks have slowed down. I'm going to share the results. So most of you said at least 37 countries. The correct answer is at least 56. DMPA-SC is registered for self-injection in at least 56 countries, including countries across Sub-Saharan Africa, Asia, Latin America, Europe, the United Kingdom, and the United States. 43 of the 56 countries included in the Access Collaborative databases are lower middle income countries. So at least 43 of the 56 are LMICs. And I think that there are often questions about DMPA-SC registration for self-injection in the United States, and DMPA-SC is registered for self-injection in the US. Thank you for participating there with us. Again, if you have questions around any of if you have questions on the polls that we showed, please do drop those in the chat. If you have any questions for our first three speakers, for Alan, Lusungu, and Beke, please do share those in the chat. And we're going to move ahead towards our next two speakers, who will actually be sort of sharing some information as we talk about South Sudan. So first, I'll introduce them together. So first, you'll hear from Lua Luka, who is the Sexual and Reproductive Health Research Manager at the International Rescue Committee based in South Sudan. He currently leads studies on self-injected DMPSC and implementation research on the community-based maternal and newborn care in rural settings of South Sudan. With more than 5 years of research experience, Lul has previously worked on studies in Malawi, Kenya, Somalia, and South Sudan, with a focus on gender-based violence and sexual and reproductive health. Then we'll hear from Dr. Abram Tubo, who is a medical doctor by profession with over 15 years of experience in the field of SRH and humanitarian development settings, family planning, basic and comprehensive obstetric and neonatal care, and obstetric fistula surgery. He holds a master's degree and MPH, reproductive health and population from the Uganda Martyrs University in Kampala, and an undergraduate degree in medicine and surgery from the Upper Nile University in Sudan. I'll hand it over first to Lual.
Thank you so much, Ebony. My colleague and I will be presenting to you the factors associated with uptake and continuation of DMPSA self-injection in South Sudan, a mixed method pilot study that we conducted in rural and urban settings of South Sudan. I will give an overview of the study and also findings from the rural side of the study, and then my colleague will present findings from the urban setting. Next slide, please. Our study was, we conducted the study in Awilis and Juba, 2 counties of South Sudan, a country that is grappling with some of the worst health indicators in the world, including maternal mortality rate, which stands at 1,150 deaths per 100 live births, and an estimated 30% of unmet needs for family planning among women of reproductive age. As a study team, we realized that DMPS, self-injection of DMPSA, which is a small and a light device, as you can see in the picture, can be self-injected by untrained persons, can help in tackling geographical and other barriers to access with health system and privacy issues. However, we realized that the feasibility of such study or the self-injection of the DMPSA in humanitarian settings and among low-literate women has not been adequately tested, and therefore it was important for us to pilot it in the setting of South Sudan to see if low-literate women will be able to self-inject. Next slide, please. We had 3 research objectives that we wanted to achieve in this study, and one of them was to determine the ability of women and girls in urban and rural South Sudan to self-inject accurately and in a timely manner, considering that most of them are low literate, and also to determine the continuation rate over a period of 1 year in rural and 6 months in urban settings, that's in Juba and Awil. And finally, to describe the acceptability and demand of the self-injection model among users as well as stakeholders. Next slide. Our study, we use mixed method prospective cohort study, where we enrolled and followed participants in rural setting for a period of 12 months. And over that time, we collected quantitative data on social demographic and utilization so that we understand the profile of people who are part of the study, as well as their use of self-injection over time. We also collected data around experiences with self-injection and also reason for discontinuation of use for those who dropped out in the study. As I mentioned before, we conducted this study in rural and urban center so that we can see the differences or the challenges that women in rural and urban phase in terms of accessing the family planning services. And as we know that we have two arms of the study and they were conducted in two different settings, we use different recruitment strategies. In rural setting, due to gender dynamics, we relied very much on community health volunteers who were recruiting or informing women about a pilot of self-injections at the health facilities that they were attached to, and then referred women who were potentially eligible and interested in being part of the self-injection study. In Juba, we used a direct recruitment from the health facility, where the service providers were given information about the pilot of the self-injection within the health facilities that we selected to be part of the study. Those who were interested in participating in self-injections were referred to the research team that was based in another secure location where women were taken through screening, informed consent, and those who consented and trained on self-injection and demonstrated competent to self-inject were enrolled in the study. The first round of data collection, which was baselined, happened at the health facility, but the subsequent follow-ups were happening at either home of the participant or at the comfortable locations where the safety, privacy, and confidentiality of the participants were not compromised. We analyzed the data that we collected over the periods of 6 and 12 months using both descriptive and inferential statistics, as well as thematic analysis for the qualitative data. Next slide, please. I'll be presenting to you the findings from Awiles, which is the rural arm of the study. Next slide. In terms of social demographic information, our study, we found that the median age of the study participant was 28.5, with the youngest being 17 and the oldest as 43 years old. Majority of our study participants were married, they had no formal education, and walked to the nearest health facilities to access services. Again, majority of them were first-time contraception users, with some of them, or majority, also having an intention to have a child in the future. In terms of decision-making about family planning use, we found that 65% of the participants make decision on their own, while 34% make decision together with their partners. In terms of perceived support for the family planning, 50% of the study participants reported their community being supportive, as well as 41% reported their husbands or partners being supportive of the use of family planning. Next slide. Factors associated with self-injection. We found that over the 12-month period of follow-up, 57% of women continued to self-inject, meaning that majority of women in rural area were likely to self-inject for 12 months consecutive. However, we have also seen dropout or discontinuation of self-injections, and these were the reasons that 109 participants discontinued use. One of them was because they were not able to remember to self-inject on time. Side effects contributed to discontinuation, pregnancy, and improper self-injections. So improper self-injection contributed 5% to the discontinuation of self-injection. We also found out from our study that the number of pregnancies was significantly associated with continuation of self-injection, both at month 9 and month 12 among the study participants. Next slide, please. We also asked women, our participants, about what they perceive as benefits of self-injections, and 3 things came up, and these were including the convenience, because they believe that having the doses at home to self-inject any moment they want it reduces the travel time to the health facility, and then ease of use after the training. Women believe that after being trained on how to self-inject, they can use it easily. And then also a mention was the privacy, because as we have seen from the finding before, 65% make decision on their own, meaning that they do not want their husband or partners or other household members to know about their use of family planning. So they think that using self-injections will improve the privacy. Also, questions around challenges that they experienced were asked, and women reported three things, and one of them was activation of the self-injection device. Women think that they struggle with the self-injections and forgetting the re-injection date, and finally, side effects were very prevalent among the study participants. Next slide. We also asked women how they remember the re-injection date, because we know that majority of them did not have some level of education to be able to read or write. And they mentioned 4 ways that they could use to remember a re-injection date, which included asking CHVs, children, fellow participants about the date, tracking and checking on the phone calendar, that could be their own phone or the husband's phone, counting monthly period cycle, market days, announcement in church and radio, and also following the written note which was given to them by the research team. We have also realized that some of the study participants kept the date given for the next self-injection on their mind, and they remembered the date. However, some completely forgot the date and could only remember the month they were told they're supposed to self-inject. And this is due to low literacy. Yeah, next slide. We also try to find out where women store and dispose the used devices. And we realized the most popular storage used by the study participant was chaff containers hidden in bedroom or another private rooms. The reason the chaff or the devices were eaten was again in relation to them not letting the husband or some household members know about the use of family planning. In terms of disposal, latrine chaff containers, which were provided by the research team, were the commonly used disposal options by the study participant. Some participants also returned the used devices to community health workers who were living within the community with them, or even to the health facilities for disposal. Next slide. What does the finding imply? And as we have seen, the continuation rate was 57%, meaning that majority of women were able to self-inject. And this shows that the self-injected contraceptives are suitable for low-literate women of reproductive age in rural humanitarian setting. We have also seen late self-injection and side effects contributed to discontinuation of self-injection. So we need to improve reminder system and referral linkages to help providers to manage side effects, because even though it's a self-care intervention, we need to ensure that there are always support system in place to ensure that the side effects are managed really well and timely. Participants stored and disposed devices in safe and unsafe ways. So we need to explore the contextually relevant and innovative methods that women can use to dispose of the used device and also to store their devices before they use them. We have also noted that health facilities and providers continue to provide important links for addressing side effects and collecting used devices. So there's a still need for the health facilities to continue being there in terms of disposal of the used devices. And then we also need to explore mechanism for continuing to support women in self-injection retraining in future program. As we have seen, 5% of the study participants discontinued use due to improper self-injection. And if they were retrained on time when they were supposed to self-inject, they could improve on self-injection skills. These are the findings from the rural side of the study. I will hand it over to Dr. Abraham to present the findings from the urban arm of the study, and will be able to answer to your questions later, if that's possible. Thanks. Over to you, Dr. Abraham.
Thank you very much, Lual. in regards to Juba as he has mentioned, Juba is the capital of South Sudan, so it's like an urban setting. Next slide. It's like an urban setting. In terms of socio-demographic characteristics, we would find that participants were young women. The median age is 26.7. Most of them are married with a median age at marriage of 18.9 years. More than half had secondary education and above because of the urban setting, and they use public transport and traveled for less than an hour, than half an hour to access a nearest health facility. Participants were also either in business, 54%, or formal employment, with very few farmers. Most participants had previously used other family planning methods, opposite to what my colleague has presented. Family planning also decisions are made by participants, 71%. However, half of the participants felt that the community and also partners are not supportive of family planning use or uptake. Yes. Factors associated with self-injection continuation. Study have found that self-injection continuation rate at month 6 was 75%. And then majority of urban women were likely to self-inject continuously beyond 6 months. Women who perceived their community as supportive of family planning were 2.7 times more likely to self-inject. And then also older women, and this answers the question of one of the participants, I just saw it in the chat. Older women were more likely to self-inject than younger women. For instance, for each year older, the chance of self-injection increased by 80%. When it comes to the injection status, as you could see over there, you can go to the next slide, please. In terms of acceptability of self-injection among women, we found that perceived benefit of self-injection contraception, like it has been mentioned in other studies, ease of use at home, it enhanced self-care, and also eliminating the need for daily administration. And it is very convenient because it reduced frequency for facility visits, and also it is so confidential. However, there are challenges in using self-injection. Just like as mentioned by my colleague, side effects is one of them. And also the less common reason reported by less than 10 women is desire for pregnancy or difficulties with injections, like he has mentioned. Yes. Storage and disposal. Like he has mentioned by my colleague from Liberia, the common storage was suitcased, over 50%, followed by handbag. And also other storage was hanging also on the roof. And here, actually, the participants, they were fearing partners more than children, like it has been mentioned in other study. Almost all of them stored the device at home. The concerns, like I've mentioned, is included husband discovering the device and also loss of device. And in here, because like we have said, most of them are not being supported by their partners or community members. 6 women in month 3 and 3 women in month 6 shared their doses with their friends and also relatives. And also this graph, it shows the popular disposal places. The highest was in latrine, and then the sharp containers provided by the study team. Next, please. Ways to remember the date of self-injection. Actually, most of them, 71%, they have remembered. However, 13% have to write it down somewhere. 6% they put it in a phone or a calendar. 4% of them were reminded by community-based distributors. These community-based distributors were part of the study team. They were based at the community level, and they were very useful in terms of mobilizing women to reach the study sites. And also the research team has also helped in the reminders together with relatives and neighbors. Next, please. What are implications of the study? Actually, we have found that women showed ability. So now we are very confident that women are able, and also they are demanding for self-injection. However, the experience of side effects influence women to discontinue use. That is calling for strengthened counseling and communication with participants around side effects, and also creating linkages for addressing side effects. Other thing, also community support. Like we have seen, half of the participants have mentioned that their community are not supporting. So there is a need of community support is very essential for promoting self-injection continuation. So every health program or policies should also strengthen and expand community-based interventions. And also social or gender dynamics, it influences women to discontinue use. And therefore, male engagement is crucial in contraception programs. Also, like I've mentioned, community security for self-care is essential to ensure all women who need self-injecting contraceptives have access, and also that will curb dosage sharing, like I've mentioned, because of shortage. So some participants, they were sharing their doses. So there is a need for community security, means securing the community from January up to December. Next, please. So what's the next step? We I think the team is thinking of dissemination. That means engaging government and also international communities in different forums, just like this one. And also we need to develop research articles and blogs, and also policy briefs. However, there are needs also for further research areas. For instance, health system preparedness for self-injection contraception is scale up. To what extent is the health system is ready for the scaling up of self-injection? The other thing also is the visibility of self-injection among the adolescents and also women living with disabilities. And last not the least is the study on social-cultural factors on self-injecting contraception uptake. Yes. And finally, I would like to thank the study team, right from South Sudan Country Program, I will cite, which is led by Lual, and also IRC headquarters, led by Dr. Naoko, and the co-investigator, Dr. Mamatena, and other collaborators like myself and my team. Thank you very much, and over to you, Ibani.
Thank you so much, Dr. Chubo. And Lual, for those presentations on South Sudan. We now are going to take a moment to respond to some of the questions that have come up in the chat. So first, I see a question from Lily. The question reads, is the DISC package available for adaptation, implementation in other countries beyond the pilot? Lusungu, I'm going to hand it over to you to answer that question, if you will.
Hello, everybody. So we are responding. Apologies, it's raining heavily out here. So can you come again?
Would you
Are
like
we
me to
responding
repeat
to
the
the question?
Yes. Is
Yes.
the DISC package available for adaptation or implementation in other countries beyond the pilot?
So I wouldn't be able to respond to that one because I only know in reference to Malawi to say I don't think it's a pilot country, but we are implementing the DISC project.
Sure.
So,
and I can share that the DISC project is also being implemented in Uganda and in Nigeria. The team, the prime is PSI, and they have resources that you can find available both on their website and on the Injectables Access Collaborative website, on the Moment of Truth training, and some other information on the overall project, Discovering Innovations in Self-Care. The next question came from Fatimata. Is there any legislation in force in these countries in favor of allowing private pharmacies to administer injectables, including DMPSC, and to initiate customers on self-injection? Alan, would you like to take that one on pharmacists' administration of injectable DMPSC?
In Uganda, we do not have a policy allowing pharmacists to administer DMPSC. We are currently going through the advocacy process to have DMPSC, including self-injection, approved to be provided in pharmacies, but not by pharmacists, but rather nurses and midwives who work in the pharmacies.
Awesome.
However, we have approval for drug shops, provision of injectable contraceptives and initiation of self-injection through drug shops. Over.
Thanks. And I can share, to Alan's point, there's advocacy happening in a number of geographies in order to open up the pharmacist channel, and to really use that as a place for private sector engagement around DMPSC and self-injection. Depending on the geography where you are, in some places, pharmacists are already authorized to administer injectables. In other places, that's not the case, and partners are carrying out advocacy in order to support that. In some places where we already see providers providing injectables, there's advocacy and work being done in order to support pharmacist training, in order to train women in order to self-inject. It's a very active conversation in many geographies, and many of our partners, including folks on the call, are supporting work in order to really engage the pharmacy sector. Nina asked a question. Can you comment whether reasons for discontinuation differed by age, group, adolescents, and young women versus older women? And so I think we started to hear some of that from Dr. Abram, but if you have anything else to add, Dr. Abram, please come off of mute and share about the discontinuation in different age groups. And I'm not sure if you all might also want to come in and share about the different age groups and discontinuation.
And thank you so much, Evans, and thanks to Nina for the questions. In Willis, we never observe any difference in the age group in terms of discontinuation of the self-injection. So it will equally the same, so all different age groups of all the study participants. And one of the surprising things about the rural setting was that most of the study participants were older women, especially, with just very few of them that were in the age group, let's say 17 to 20 something. So we have to respond to that question. We haven't seen any differences in reasons for discontinuation according to the age group, but rather anyone can discontinue regardless of their age. Thanks.
Thank you for that input. There was a question on some of the commonly reported side effects, which I see while you began to answer in the chat, including missed periods, headache, backaches, and irregular bleeding. Would any of our other presenters like to share around some of the commonly reported side effects that that are present in the geographies where you're working or in your the clients that are being served?
Those were the commonly reported side effects in both urban and rural settings in this specific study. Thanks.
Becca, I'd go to you, and I wonder if you have any feedback in Liberia on some of the commonly reported side effects of DMPASC or in the experience of self-injection.
Thank you, Ebony. Our study, the scope of our study did not cover the issue of side effects. So there is not a lot that we learned from that area. Thank you.
Thank you. We have a question here from Kim. Several presenters referenced stock out of DMPASC as a challenge. Do we know if there's anything specific to DMPASC that is contributing to stockouts for this particular product, or is it just facing stockout challenges like many other contraceptives do? I'll open that question to all of our presenters. Feel free to come off of mute. Alan, I see you're in the
Can
chat.
I come in?
Oh, sorry, Lusungu, you can start, and then we'll head over to Alan.
Okay, so one of the challenges that we have is that there's only one manufacturer for DMPA, that is Pfizer. So recently with the coming in of COVID, it was more like sorry for the background noise. It was prioritizing the production of the vaccines rather than the production of the injectables. So at the end of the day, countries are suffering because there's only one manufacturer who is also into production of other healthy related products. Yeah, so that is one of the main challenges that we have. And then at the same time, we also have the challenge of reporting, where our public facilities have issues, a lot of issues when it comes to completeness and timeliness of reporting into our digital platforms. So because of the low data that is coming in, the quantification exercise is also affected. At the end of the day, the procurement is based on the low data that has been reported, and then our facilities tend to suffer the loss of stockouts. Over.
Alan, over to you.
Yes, in Uganda, stockouts are not uncommon. They affect most of the contraceptive products. However, the challenge is compounded for DMPASC particularly is compounded because for self-injection, for someone to optimize the benefits of self-injection, they have to take multiple units home for independent self-injection so that they don't keep coming to the facility as they would for provider administration. So that really compounds the issue of stockout. And for Uganda and also maybe other countries where self-injection has not been fully institutionalized, including getting it into HMIS, we are lucky we've gotten there. If it is not properly tracked, as just previously mentioned, then you stand a chance of not getting accurate information or data to inform decision-making like quantification and forecasting for DMPASC, especially if you have clients who are self-injecting and others who are getting it through provider administration. Over.
Thank you, Alan. Betty, I see you asked a question around pharmacist administration of vaccines in Malawi and Senegal. I see that we had responses from Lusungu and from Farmata at PATH around pharmacists, advocacy for pharmacists to administer injectables, but I see this question is specific to vaccines. Lusungu, Farmata, would either of you have information on the administration of vaccines in pharmacy channels in Malawi or Senegal?
So currently in Malawi, we do not have a policy that governs that pharmacists should administer vaccines or the injectables. It's only that the advocacy process has just started, where the country reproductive health directorate under the Ministry of Health just drafted an MOU which should ensure the transitioning so that the pharmacists are able to give out the injectables. But for the vaccines in Malawi currently, we are not doing that. Yeah.
Thank you. And I see Farmata in the chat sharing that she doesn't have any information on vaccines in Senegal. in terms of pharmacist administration. Before we close, I just wanted to circle back. There was a question on the poll. And so just to clarify that the 56 countries, at least 56 countries where we see registration of DMPSC does not mean that DMPSC has been rolled out or self-injection is a mode of administration. That's simply about product registration and the details of product administration. With that, I'd like to thank you all. You can go to the next slide, I think. Just thank you all for your participation in this session of the Self-Care Trailblazer Group. Please take a brief survey to provide feedback on the session. You'll see Kimberly shared some links in the chat. If you could please just take 1 or 2 minutes to provide feedback on today's session. And of course, the self-care learning and discovery series continues. So please do check out some of the other sessions that will be taking place in the coming weeks. And we thank you again for your participation. I didn't get that.